Let's jump right into this explainer, where we're going to take the high-stakes, adrenaline-fueled world of general surgery and strip away all that dense medical jargon. We're going to look at the human body exactly the way a general surgeon does, as this incredibly intricate biological machine that every now and then needs some seriously high-stakes mechanical repairs. But before we dive into the actual anatomy, we have to talk about the absolute hardest split-second decisions a surgeon has to make. Picture this. Things have gone catastrophically wrong. The emergency room doors fly open, and there's absolute chaos. How do they actually prioritize life and death? Well, it's definitely not about who yells the loudest. It all comes down to a highly structured, unbending system. Here is our game plan for today. 1. Triage and trauma protocols. 2. Gastrointestinal surgeries and emergencies. 3. The mechanics of hernias. And 4. We'll step inside the operating room. Let's kick things off with Section 1, Triage and Trauma Protocols. So managing that ER chaos comes down to the color-coded triage system. This is the absolute foundation for figuring out who gets resources when multiple patients roll in at the exact same time. You've got red for maximum priority. These are your immediate life-on-the-line emergencies. Yellow means urgent, but they can wait just a short bit. Green is for delayed, minor injuries. And then you have the grim reality of triage. Black. That's the lowest priority, meaning the patient is unfortunately deceased. This system completely removes emotion from the equation. It relies purely on the mathematical probability of survival. When a patient is crashing, surgeons rely on something called damage control surgery. Now, you might assume they just go in and fix everything at once, right? Actually, scratch that. It is a strict, methodical, step-by-step approach. Notice Step 2, primary exploration. The goal here isn't to perfectly fix the anatomy. It is literally just to stop the bleeding and control contamination. They pack the wounds, plug the leaks, and get out. They send the patient to the ICU in Step 3 to stabilize, and only later in Step 4 do they actually go back in to reconstruct the anatomy. It's all about preserving life first, structure second. The whole reason they rush that patient to the ICU in Step 3 is to avoid this, the terrifying lethal triad of trauma. This is a vicious, deadly cycle. If the body gets too cold, hypothermia, the blood loses its ability to clot, which is coagulopathy. If you can't clot, you bleed more, oxygen delivery drops, and your blood turns acidic. That metabolic acidosis makes the body even colder and even worse at clotting. It is a total physiological death spiral. That's exactly why surgeons aggressively pump in warm fluids and blood products to stabilize the core systems before they even think about attempting further anatomical repairs. Now, for burn trauma, assessing the damage quickly is just as critical. Surgeons use the rule of nines to rapidly calculate the total body's surface area burned. It's a brilliant little mental shortcut. They assign 9% to the head, 9% to each arm, 18% to the front of the trunk, 18% to the back, and 18% to each leg. In a super high-stress environment, remembering the simple number 9 allows a surgeon to instantly calculate exactly how much fluid the patient needs to survive without ever having to reach for a calculator. All right, moving right along to Section 2, gastrointestinal surgeries and emergencies. Let's shift our focus to the body's internal plumbing. When we compare GERD and peptic ulcer disease, we're looking at two very different mechanical failures caused by stomach acid. Think of GERD as a faulty one-way valve leaking acid upwards into a pipe that is absolutely not designed to handle it. That's what causes that severe heartburn. Peptic ulcer disease, on the other hand, is like a localized acid burn, eating a hole right through the pipe wall itself, which is often triggered by an H. pylori bacterial infection or just heavy use of NSAID painkillers. So both are acid problems, but entirely different structural nightmares. But what happens when the pressure in the system just gets too high? The pipe can completely blow out. This brings us to Boerhaave syndrome, which is an absolute code red emergency where the esophagus literally tears open. This usually happens from severe barotrauma, which just means pressure trauma, often caused by violent vomiting against a closed glottis. Imagine a highly pressurized tube popping. All that stomach content suddenly floods straight into the chest cavity. So how does a surgeon spot this blown pipe? They look for Mackler's triad. They check for a sudden onset of severe chest pain right after a history of violent vomiting. But the truly wild clinical sign here is cervical subcutaneous emphysema. Because the esophagus has ruptured, air escapes and travels up into the neck, getting trapped right under the skin. When the surgeon physically presses on the patient's neck, it literally feels and sounds exactly like popping bubble wrap. The surgical fixes for these GI issues are, quite frankly, fascinating mechanical solutions. For peptic ulcer disease, if medications fail, they perform a Billroth procedure. That's where they cut out the damaged, ulcerated section of the stomach and completely rewire the plumbing. For GERD, since the valve itself is loose, surgeons do what's called a Nissen fundoplication. They literally take the top of the stomach and wrap it 360 degrees around the bottom of the esophagus, creating a tight collar to physically block the acid from splashing up. Okay, section 3, the mechanics of hernias. Let's talk about hernias. A hernia is essentially an inner tube bulging through a weak spot in a tire wall. It is caused by anything that heavily and repeatedly spikes your internal pressure. We're talking a chronic cough from COPD, heavy weightlifting, straining from chronic constipation, or even weakened collagen from smoking. That repeated, massive spike in intra-abdominal pressure eventually pushes the intestines right through the weakest point in the abdominal muscle wall. Now you have to understand there is a massive difference between an annoying routine issue and a life-threatening emergency here. A reducible hernia just means the bulge pops out when you cough or stand, but you can safely push it back in, no big deal. But if that bulge gets trapped, which is called incarceration, and it swells so much that it chokes off its own blood supply, well, now you have a strangulated hernia. That bowel tissue is instantly starving for oxygen. It'll become ischemic, it will die, and it will perforate if the surgeon doesn't operate right that second. To make things even trickier, there's a very specific, incredibly dangerous variation called a Richter's hernia. Instead of a whole loop of bowel getting stuck, only a tiny pinch of the bowel wall's circumference gets trapped in the defect. Because the whole tube isn't completely blocked, the patient might still be passing food normally, which completely masks the problem. But that tiny pinched piece of tissue is still strangulated, meaning it can quietly become gangrenous while the patient thinks they just have a minor stomachache. So how exactly do we patch the tire? A surgeon has a few tools in their kit. A herniatomy is simple. It just removes the sac itself. A herniorrhaphy, like the shoeless repair, is a pure tissue repair, where the surgeon sews the patient's native muscles and fascia right back together to close the hole. But often that tissue is already pretty weak, so they perform a hernioplasty, like a Lichtenstein repair. Here, they reinforce the wall with a synthetic mesh. This creates a tension-free patch that acts just like rebar in concrete, ensuring that the wall never gives way again. Finally, let's head into section 4, inside the operating room. When a trauma patient is crashing, fluid resuscitation is everything, and the size of the IV cannula literally matters between life and death. Check out these flow rates. An orange cannula, which is a large 14 gauge, can dump a massive 240 milliliters of life-saving fluid per minute into a patient. Compare that to a tiny yellow 24 gauge cannula, which only pushes a measly 20 milliliters a minute. When you are fighting that lethal triad of trauma we talked about and trying to replace lost blood volume instantly, you desperately need the orange pipe, not the yellow one. Once the surgery is done, the body's inflammatory response immediately kicks in, and fluid or blood can quickly build up inside those newly repaired cavities. To stop this, surgeons leave behind drains. They might use passive drains, like a Penrose drain, which are simple, open systems that just rely on gravity to let the fluid weep out. Or, for much more controlled fluid removal, they use active drains, like a Jackson Pratt. These are closed systems that use a squeezed silicone bulb to create continuous negative suction, actively vacuuming the surgical site completely dry. To wrap things up, looking at suture removal times gives us a fascinating glimpse into how different human tissues heal based entirely on their blood supply and mechanical stress. The face, for instance, is incredibly well vascularized, so it heals incredibly fast. Those sutures come out in just 3 to 5 days to prevent scarring. But the thick, tough skin of your palms and soles, they're under constant mechanical tension, so they take a full 2 to 3 weeks to bridge that gap strongly enough to have the stitches safely removed. Seeing the human body broken down like this, into pressures, pipes, and patches, leaves us with a really fascinating realization about medicine. It's a discipline that demands a complete mastery of both complex biology and raw structural physics. If modern surgeons can reroute our stomach acid, patch our abdominal blowouts with synthetic mesh, and instantly calculate flow rates to reverse a physiological death spiral, well, it forces us to ask, are they simply the ultimate biological mechanics? Hopefully, this explainer has completely transformed how you view the incredible, high-stakes craft of general surgery. Thanks for exploring the surgeon's playbook with us.